And thank you everyone for being here. Today is Thursday, May the 1st, first day of May, and this is Journal Club for CMDA. My name is Singh Pallet. I'm the president of CMDA. We're glad to have all of you with us today. Our presenter for today is Travis Neill, PA, and he's going to talk about bias in clinical decision making. I've read some of Travis's work before, and I know this will be really great. Travis, go ahead.
Thanks, Singh. And thanks for those of you tuning in. I imagine you're dealing with information overload, but I think this is an interesting topic. The idea of how bias infiltrates our clinical decision making. And I think it's particularly important in healthcare. Um, I'm going to start, though, with a story. So, about 13 years ago, my father passed away from end stage COPD at the age of 70. And for the last year of his life, his pulmonologist had him on oral prednisone, and he was taking him from 5 to 10 to sometimes 15 milligrams and then back down. Tried him off a couple times, but it really seemed to make a difference in my dad's symptoms. And then after he passed, I began prescribing oral prednisone to virtually all of my advanced COPD patients. And I did this despite knowing the gold guidelines. I did this despite the physicians and medical directors that I worked with questioning what I was doing, telling me that it wasn't the standard of care. And I do remember kind of, these sort of rationalizing it, downplaying the potential negative effects and kind of focusing on more of the potential benefits. And this went on for a while until I was involved in a research study for COPD and long-term care. So I was reviewing the care of dozens of residents of other providers, and it just sort of hit me while I was doing this when I noted that very few, if any of them, were on oral prednisone. And so I had kind of this really sort of shocking realization, and it led to a couple of things. One was I stopped prescribing oral prednisone to everybody, but it also just made me wonder what else. What else was I doing where I had this big blind spot? And essentially, what happened is because I had associated this medication with a relief of the suffering of one of the people I love most in the world, it just implanted this very strong bias. And it was, definitely unconscious. I don't think I actually heard, people when they would tell me this wasn't good for patients. And so because of the strength of the emotional connection to it, it just became a very, big unconscious bias and blind spot. So what is implicit or unconscious bias? So it's preconceived notions, prejudices, or beliefs that influence our decisions and lead to unequal or inaccurate outcomes. And it really has basically three important characteristics. And we need to remember that we rely on stereotypes and assumptions just for efficient decision making, even when we're trying to attempt to be objective. The problem in healthcare is that this can lead to decisions that directly impact people's lives. So the first characteristic with unconscious bias is that it operates at the unconscious level. So by its very definition, we're not aware of it. And we can't just sort of self-reflect and suddenly become aware of these things. We really need outside sources and tools to kind of highlight our biases.
Oh,
Like explicit bias, these are things that beliefs and attitudes that we are aware of. An example would be, I have sort of an explicit bias towards do not resuscitate in patients in their 80s and 90s, and sometimes I'll even tell a patient or family member that I have this bias. But we are aware of those. Implicit biases, by their very definition, we're not aware of them. Second characteristics, oftentimes these unconscious biases run contrary to our stated beliefs. So, for example, you can claim that you're committed to treating patients with chronic pain with fairness and compassion, but you can have a pattern of undertreating their pain. And both can be true. You can believe that are trying to do the right thing and that you want to compassionately treat someone's pain, while behaving in a way unconsciously that is contrary to that belief. In fact, the science of implicit bias actually says this is often true, that we tend to proclaim beliefs more forcefully when we kind of implicitly behave in ways contrary to that belief. Um, and so it's an ongoing issue. And so the third characteristic is these biases are triggered through rapid and automatic associations between people, ideas, and objects, and the beliefs we have or the stereotypes about those same people, ideas, and objects. And so the science of implicit bias says that we tend, estimates that we receive maybe 75 gigabytes of information every day, and that's like the equivalent of watching maybe 16 movies, but our conscious brain can only process about 21 kilobytes of information. That's about 5 minutes out of that total time. So all of the rest of the information is being filtered through our brain and through whatever unconscious biases that we've developed over time. And it just helps us, deal with the world and make decisions and get through it. And it's just because our brain can only focus on so much at one time. And so we end up, with a lot of gut instincts and reactions that are all filtered through that process. And so that's the science of this. We kind of all know this, that information we receive, the sensory information, it goes through the amygdala and the hypothalamus first, creates an emotional reaction before it reaches the frontal cortex. In fact, about 95% of our decisions are unconscious, going through our emotional centers first. And, so when the same science suggests that maybe in a single moment, you can become, your senses can sort of become aware of about 11 million pieces of sensory information, but you can only handle in your conscious brain 40 of those. So it really is just how our brains work and how we, process information and end up making a lot of our decisions. So this formed because people that didn't have this reaction died. So the saber-toothed tiger, whatever those quick snap judgments and reactions, that's what kept us alive. And so that's how the brain formed. And you can think about this like when you meet somebody, our unconscious biases are immediately and very quickly in under a second working to categorize them based on that initial information. So it could be their height, their weight, their race, their gender. And all of this goes through our emotional centers first, and all of our history and any biases that we have formed. And we also tend to gravitate towards likeness. So our if something or someone is a little more familiar or more like us or associated with something that in our history that was positive, we tend to gravitate to that, and we then tend to be more guarded or on edge or have a more fight or flight response to things that are more dislike this, unlike us. And so we're always categorizing based on our life experiences, and it can basically result in us, you know, really unconsciously letting all these biases drive a lot of our decision makings, and it happens so fast. That's another thing, just it's instantly without our awareness, and it's happening all the time. And so first impressions in healthcare in particular, this is particularly important. So imagine you're admitting a new patient. Every piece of information, typically starting with a chart review, you look at their med list, you look at their allergies, it immediately begins some snap judgments and kind of opinions that can generate preferences towards certain decisions before we ever even meet the patient. And then everything about their initial appearance and demeanor, it begins to create more and more of these kind of snap judgments where we could have some fairly strong unconscious biases before we ever ask them a single question. And we all do this regardless of our intentions. So these first impressions in particular, they have a major impact on diagnosis and decision making, and they become part of our belief system with that patient that's constantly subject to unconscious bias. And the problem is a lot of these, they're stereotypes for a reason because they often tend to be true. But, it can lead us into confirmation bias. So what's confirmation bias? So this is in medical decision making, it's the tendency for clinicians to favor information that supports their initial diagnosis or belief while discounting or overlooking evidence that contradicts it. And will it is documented throughout the research that an implicit bias that providers regularly overestimate the benefits and underestimate the adverse effects of any medications that we prescribe. And that's normal. We're in the business of helping people. We often identify with, you know, uh, good ethical principles. And so it's harder for us to see that information that, we may have actually done something that caused harm. There's, the basically the concept of blind spots. I love this quote. Historian Thomas Carlyle says, "The greatest of faults, I should say, is to be conscious of none." And what happens is the more experience we get and kind of the more entrenched in our field, it's actually more likely that we're going to develop these strong unconscious biases. And it's harder for us to walk back from something that we believe to be true. There's a concept out there called Nobel Prize syndrome. And basically what it is a good percentage of Nobel Prize winners, they end up embracing some type of conspiracy theory or junk science that is outside of the field, that they're an expert in. And often it's like slightly adjacent, if it's science field. And so, with the theory is basically this feeling of overconfidence and an inclination to kind of express opinions on subjects that are outside of your expertise because of, all of the sort of prestige and quite frankly just intelligence. Like highly intelligent people that are experts in a certain area will often think that that intelligence applies to all areas. I can think of a fairly public person that's kind of like that. And as a result, it can lead to essentially believing in things that, if we took a step back and looked at, would seem crazy. Dunning-Kruger effect. This is essentially, individuals with low ability in an area, they basically overestimate their competence. I mean, we're seeing this with, the way we receive information online and get little snippets of things here and there. And the more that they confirm to our belief system, the more likely we are to believe them strongly. And I think the evidence says hearing it 3 times from different sources, no matter the source, is enough to kind of solidify a belief to the point where people won't even hear information that's contrary to it. So again, whether it's a matter for us of prescribing something to everyone that they don't need, or never prescribing a medication again that could really help someone because we had some kind of adverse event with maybe a single patient, we just need to realize this is kind of an inevitable part of our decision making. And the it's interesting point is that our emotional state at the time. So if we're with a patient and we're tired, stressed out, it will actually, as humans, we tend to then lean more on our unconscious biases and stereotypes and judgments because it's easier, because it takes effort and attention to use the prefrontal cortex and focus on things. And so being tired, being stressed out, it will actually engage more of kind of that reptilian part of the brain, because it's more automatic. So it can definitely affect our decision making. So what is cognitive dissonance? This is basically the mental discomfort experienced when you try to hold two conflicting beliefs, values, or ideas. And in medical decision making, the clinician might feel dissonance when new evidence comes that contradicts a long held practice. For example, something that someone has done for a long time, it's now shown to be ineffective. And it's very common for clinicians to kind of dismiss the new evidence in order to reduce that discomfort. And the important thing about this, or the helpful thing, is to recognize that it's uncomfortable and that we can use that as a tool to kind of gain some more awareness that we may have a bias. So when we receive new information from anything, about anything, if it makes us uncomfortable, we can learn to kind of get curious about that instead of, pushing back on it or rationalizing it, or, kind of getting more entrenched in our beliefs. And so we can use that as a way to identify some of these. Examples of this would be, long term use of pain, recent aspirin for primary prevention. I've heard providers talk about it in a way where, they kind of rationalize, well, been on it for a while, don't have any. Um, and so there's this whole process of kind of being resistant to long-standing practices, despite, getting good information, that there's actually more harm than good. So specific challenges in,
Hey, Travis,
teams
I'm
of
not sure if
providers.
it's just me, but the sound was getting just a little garbled the last few seconds.
Okay,
Don't know if there's any change.
let me see if it's my connection. Can you hear it?
I can hear you now. Want to try again?
Yeah, is it just stop me if it's garbled.
Sounds good right now. Yeah, thank
Does?
you.
Okay. All right. Um, and so, we have to interact with all these different personalities in long-term care, and the the their perceptions and, opinions of us can dramatically influence the quality and quantity of the information we receive. When I've helped new providers kind of acclimate to long-term care, I've always said, it's, you really have to try to not have a bad day. And the problem comes when, one negative interaction with a staff member, it can often take between 5 and 10 positive interactions to mitigate whatever the effects were of that one negative interaction. And, when we're, in this team-based environment, and this is, how we provide a lot of the care, you can think that, the staff, if we have a negative interaction, they're less likely to give us information. They're also more likely to tell us things that we want to hear, whether they're entirely accurate or not. The same can be true with positive interaction. So a well-timed, genuine compliment can have a great effect on, developing that rapport and getting good information from staff. And the fact is that, the ego creates more dissonance and more bias. So that's the problem. Let's talk about some ways that we can mitigate against the effects of bias. So this is a list of some solutions I'm going to go through in the next few slides. And the question that I asked myself, about a decade ago was, how often is this happening? And, is there any way that I can become more aware of it and kind of hedge for the effects? So we're going to go through each one of these. The first one, and this one, especially in the last few years for me, has just been a kind of a game changer for my practice style, and that's shared decision making. So just the basic process of asking patients certain questions to gauge where they're at and what their goals and their values are. I had a student with me a while ago, and we came out of a patient room, and it was a very complicated patient, a lot of health issues, and she asked me, well, how do you know where to start? Like, just so much going on, how do you know where to start? And so I said, well, let's go back in. So we went back in and we asked some of these questions. What's your understanding of your current health right now? What are your goals and priorities? What are you most afraid of? And when we came out, it was actually very clear to both of us where to start. And so this becomes a hedge on our own kind of biases and opinions, and what we think should happen is using shared decision making to kind of keep some of that in check, but also help prioritize a lot of those decisions. You also get a lot better adherence to treatments, and really just a check on bias. Another big one is inviting opposing opinions. I'd say nobody is particularly comfortable with this. And, for me, a real positive thing in my career has been my relationship with Dr. Gom, in that you know, his you know recommendations or critiques as medical director, and I from really early on I would respond and often challenge him, and we'd have discussions about it and kind of go back and forth. And really I think one of his best traits is that he was open to that, that he did listen. And I think he was basically just looking for a response. And but it really kind of shaped my care and willingness to invite critiques. And in long-term care we do have the advantage of often sharing most of our patients with another provider. So you can create this sort of open dialogue where you actually call up, as a PA, call up the physician and say, hey, I'd like you to look at the care on this patient, or maybe a certain practice that you're doing, and really invite the criticism and be open to it. It really can help highlight a bias that we are simply not aware of. And because the greater basically the stronger the bias, the greater the discomfort will be when it's highlighted. And I love this, learning the power of silence. So this is another great way to kind of mitigate for this is, if you're in a room where they're having kind of a heated discussion, or some arguing or conflict, is learning how to basically just be quiet and listen and pay attention to the things that make you uncomfortable, and just get curious about it. And often that's enough to kind of highlight, well, maybe I have a strong bias in this particular area. Even if you're not completely aware of it, I think the silence and the curiosity is really what can be incredibly helpful. um, and then another thing is the use of algorithms or pre-established tripwires. So, the individualizing care is important, right? Evidence-based standards and checklists, they can really help us refine judgment, and basically and a more discriminating eye for, excellence or flaws in the process. So checklists, and Atul Gawande talks about this in the checklist manifesto. It can really help us with the challenges of the way the human memory works, and the way we can get distracted. And memory is really more about stories that we tell ourselves, rather than kind of this accurate replay of previous events. And all of these stories are painted with our unconscious biases, and it will absolutely affect our memory, both based on past events, but also our biases in the moment with the patient. So having checklists or using an algorithm, it really kind of can help us weed out some of these biases, and with our clinical decision making, and to try to be disciplined about it. So even if you've looked at an algorithm several times, getting in the habit of checking it each time you're in that decision making process, it becomes sort of a disciplined tool to highlight any of these biases. Another great example of this is the John Hopkins clot prevention checklist. Excuse me. It was implemented in 2006, and they implemented it based on a pretty high rate of what they deemed to be preventable clots in the trauma patients coming through the hospital. And so they implemented this, and it absolutely worked to reduce the overall rates of preventable clots from like 45% down to 10%. But the real sort of crazy thing was that it also highlighted and erased a gender bias, where prior to the checklist, women trauma patients going through there were 50% more likely of dying from a preventable clot than men. And after they implemented the checklist, it completely went away. And there's theories on why that bias was there in the first place, whether it was not believing some of the reports that women were saying, thinking they were more emotional than physical. There's a number of theories, but the point is the checklist essentially eliminated it. So these can be very effective tools. And then tripwires, which basically The idea here is you have kind of a preset benchmark in the future for a given treatment. A good example would be a feeding tube. Hopefully you're not doing feeding tubes, but if you are, and you say, we're going to try this for 30 days and we're going to have these benchmarks that we're going to look at. Maybe it's weight, maybe it's nutritional values, maybe it's alertness, maybe it's avoiding infections. And then at the end of 30 days, the agreement is if we haven't seen changes here, we're going to remove it. And this can be, particularly in, helpful, when there's a lot of effort and emotion that's already been invested in something. And that's, the sunk cost bias, which is basically when you've invested a lot of time, energy into something, you tend to keep going with it despite the information that is telling you it's not working. I can also think of another example right now where that's happening. But really just, there's so much invested that it becomes hard for us to recognize that it's either doing harm or simply not working. And then separating our actions from our identity, the providers, as providers, we tend to identify with the ethical principles of beneficence and non-maleficence, the Hippocratic oath and doing no harm. And, like when we prescribe something new or treat someone, it's normal for us to seek the information that confirms that we help them and downplays that we may have done harm. And it really kind of becomes counter to a sense of identity, and that's why it can become so difficult. And it's just important to remember that being a good provider isn't that you don't make mistakes, but how you manage the mistakes and how you learn from them. And in fact, the evidence is quite clear that admitting mistakes is not only how we learn from them, you actually avoid lawsuits and you gain a lot more trust. And then understanding the difference between our own perception and perspective. So, our own perception, it's our interpretation of the world around us, and it's uniquely ours based on our life experiences and temperament, but there's no informational advantage to it. So it's just our perception of things. And, this is why so many people, I think, find themselves arguing all the time, trying to convince people of their own opinions and beliefs, because it's all just their own perception. And most people are so entrenched in this that they don't even hear the information that's contrary to it. And so we'll always know that our own perspective, our own perception of things. But if you want to be a good decision maker, a good clinician, try shifting your places and getting out of your own perception and try to get into someone else's perspective. You can do this through shared decision making, asking questions, listening more. But changing that perspective gives you a huge informational advantage. You receive more and better information. I can say that if you do that with your spouse, it could change your marriage. If you do it with your kids, it could change your legacy. And I think if you do it as a provider, I think it will, with your patients, I think it will definitely make you a better provider. And then the very last thing, real quick, is, it's just, there's great tools out there if you want to kind of test your own biases. Harvard has one, the American Academy of Family Physicians. There's techniques of sort of visualizing things and then trying to replace whatever it is you have a bias against with something else to kind of mitigate for that. Example I give is when I drive, and getting upset with all the crappy drivers out there and people cutting me off. And so I started imagining the person that did it was my grandmother. And so by replacing that image, it kind of, it took that emotional response down a notch and allowed me to engage my thinking brain and make better decisions. And then I think just talking more openly about it, we all do this all the time. It definitely affects our decision making. And so if we can kind of normalize it and talk about it more, inviting challenges to our opinions, I think it can really make a difference in our clinical decision making. And I think that is it, as it's 1 o'clock.
Wonderful. Thank you, Travis. In the 1 minute we have left, does anyone have questions? I wonder, Travis, if you'd be willing to share references for this if we want to read more. Is it more in the clinical literature where you're, oh, there it is. Okay. Oh, very
How many
long list of
pages?
references. Yes.
Yeah, no, I can share the presentation, sure.
Yeah, thank you. Do you find this literature to be in the clinical literature where you're finding about bias in medical decision making, or I don't know, psychology or other disciplines?
So a little both. I tried to focus on the effects in healthcare. And so, specifically giving, I mean, there's all these examples of these systemic biases and things that have happened over the years in medicine, that kind of add fuel to this, the importance of this idea. So there's a lot of that out there. And then just kind of the psychology of like perception versus perspective. That's more in the general literature than the specific medical one.
Dr. Bakuri wants to know, what is the weight of that seagull?
Exactly. Exactly.
A wonderful presentation. Thank you very much, Travis. If other people have questions, please reach out. We will send the slides to everyone. Thank you very much for joining Journal Club today.
Thanks, Sing.
Thanks, that was excellent.